Thank you very much. No, I'm 100% Italian, but I spent a wonderful semester this year at the Cardiovascular Research Institute in Basel. And, yeah.
And you have a godfather and a father.
Yeah. Yeah, so for the moment, I'm still a resident in emergency medicine at La Sapienza University in Rome. And yeah, this study is about the diagnostic and prognostic value of bone morphogenetic protein 10. First, a little background. We all know, I guess, the burden of patients presenting with symptoms suggestive of acute myocardial infarction to the emergency department, and how for them a rapid diagnosis is fundamental. And there we have the champion, which is high-sensitivity troponin. But also there is an unmet need for the risk stratification that would provide benefit for their management. And in this frame, BMP10 may play a role. This is a novel biomarker which seems to be cardiac specific. It's expressed and released in the right atrium, and it's involved in heart development, cardiomyocyte differentiation, and also in angiogenesis and lymphangiogenesis. And it has been shown to be associated with different pathologies. The way we structured the analysis, we selected the APACE cohort, which again is this multicentric international study to whom some of you in the audience have contributed to, with patients presenting with chest pain to the emergency department. And we measured in frozen samples BMP10, NT-proBNP, and high-sensitivity troponin T. And then we selected several endpoints. So first of all, the diagnostic endpoint, which was index NSTEMI. Then as a primary prognostic endpoint, we selected cardiovascular death at 2 years. As a secondary endpoints, we had index acute heart failure for the diagnostic part, and then all-cause mortality and MACE for the prognostic part, again at 2 years. And MACE was a composite endpoint of cardiovascular death, AMI, rehospitalization due to heart failure, and stroke. For the analysis, we used AUC and ROC curves for the diagnostic part, and for the prognostic accuracy, C-index and time-dependent AUC. For the association, Cox proportional hazard models, and finally, for the added value, we compared especially the C-statistics. So after excluding patients with STEMI and on chronic dialysis, we were left with 4,781 patients. Of those, the median of age was 61 years, and 33% were female. I would only focus on the patients on sinus rhythm, because almost 90% of our cohort was on sinus rhythm at presentation, and most of the evidence on clinical cohorts that we have in the literature are on cohorts of atrial fibrillation. So the data are a bit different, and they already showed that there is a correlation with all-cause mortality, MACE, stroke, and recurrences of atrial fibrillation after catheter ablation. So first of all, there is a research need to explain the pathophysiology of the biomarker itself, and we did that through the partial R-square or coefficient of determination. And this is a statistical measure that allows us to explain, let's say, the proportion of variance of BMP10 through these independent variables. And as you can see, NT-proBNP is the highly associated independent variable to the biomarker. Then we have kidney function, age, and non-sinus rhythm. But again, the full model, including all those variables, only explains, let's say, less than 50% of the biomarker. Now, coming to our primary endpoint, this is the ROC curve and AUC for NSTEMI on the left. And as expected, of course, BMP10 doesn't even, it's very far from high-sensitivity troponin, of course. And also, if we compare, if we build a model including BMP10 and troponin, still it doesn't really add any value to that. For heart failure, the AUC of BMP10 is slightly higher, but still not as good as NT-proBNP, again, as expected, I would say. This is the association to the outcomes. Those are Cox proportional hazard models built with a restricted cubic splines, so we relaxed the linearity assumption, and those are dose response plots. So you can see on the x-axis the biomarker as a continuous variable, on the epsilon axis the hazard ratio. So basically, the higher the value of the biomarker, the higher the hazard. And the red dotted line is the median of our cohort, which we used as a reference. And those below are the adjustment that we use, including NT-proBNP. As you can see, there is an association with all the three outcomes. As for the prognostic accuracy, those are the time-dependent AUC. The red line is BMP10, which has quite a good AUC for all the three outcomes, but again, is quite below the other two well-established biomarker. The green line is high-sensitivity troponin T, and as you can notice, basically in the first month, it has a higher AUC, especially for cardiovascular death and all-cause death, but then after the first month, NT-proBNP takes the lead and has a better prognostic accuracy for the entire length of the 2 years of follow-up. Then we tried to investigate if this new biomarker adds any value to the already established biomarkers. So first we built 3 base models, one including only clinical factors, then a second model including the first model, creatinine and high-sensitivity troponin T, and finally a full model including also NT-proBNP. And we compared those 3 models to an extended model which also included BMP10. And as you will notice, basically BMP10 adds information when it comes to using the model with only the clinical information, but when troponin T and NT-proBNP are in the model, then basically it doesn't really help that much. So this study has strengths and limitations, of course. We have a long follow-up and a large sample size, which also allowed us to use some strong methods and to use the biomarker as a continuous variable, so not to categorize it, basically. Unfortunately, we only have the baseline determination, so we don't really know if changes over time have an effect on the prognosis. It could help us more, maybe. And also, it was performed on frozen samples, so there may be an instability, but it seems to be stable enough. Coming to the conclusion, so we know now that NT-proBNP has an influence on the variance of the biomarker of 0.36%. Then BMP10 didn't really add any discriminatory capabilities to the diagnostic performance of NT-proBNP for heart failure and high-sensitivity troponin T for NSTEMI. That NT-proBNP has the highest C index for the prognostic discrimination for all the outcomes in the analysis, and that the values of BMP10 are independently associated with the hazards of all the outcome events in the analysis as well. But again, the difference was not statistically significant when we added BMP10 to the standard of care. Thanks.
Thank you for staying on time. The panel, any questions for the candidate? Frank? Do you have a question? No? Okay. Nick, would you like to start?
Yeah, just a quick question, Luca. It's been used more in atrial fibrillation for prognosis, and although only 10% of your population had atrial or non-sinus rhythm, did you look at that subgroup to see whether you got any added value out of the biomarker there? Because often it is difficult in atrial fibrillation to interpret NT-proBNP and troponin on their own. So have you looked at that subgroup or any other subgroups?
Well, we looked a bit more especially in the diagnostic value for arrhythmias, let's say, so that, of course, those were ECG performed at presentation, so we were guessing maybe it could help in identifying patients with atrial fibrillation that didn't have atrial fibrillation at presentation, but for that, the R under the curve was quite small, just 0.6. We also looked into stroke as an outcome, but again, the number of patients with the event was quite low. It was 68 events, and it didn't seem to be associated, but I guess it's quite a different cohort for what is analyzed in the literature.
You mentioned several times that BMP10 was not, was doing good. In fact, because today, unfortunately, there is NT-proBNP and troponin that are doing so well. Yeah. Then it's like the guys who are running with Usain Bolt. I mean, they said, "Why I was not born 10 years before, 10 years later." When you looked on subgroups, you didn't find any subgroup that were really the results
we saw that
maybe similar
to NT-proBNP.
Yeah.
I mean, in the observed zone of the ESC 01-hour algorithm, it seems to add discriminatory capabilities to NT-proBNP in the diagnosis of acute heart failure.
Okay.
Yes.
And the observed zone, if I remember, how many patients it was, like 20%? Like
It's 20%, it was 960 patients.
which is, at the end of the day, it's really useful, at least in our clinical daily practice.
It's, yeah, huge impact.
Okay, thank you very much, Luca.
Thanks.